Sepsis is the most preventable cause of death worldwide. It affects 47 to 50 million people a year. At least 11 million die.
Many survivors face long-term consequences, such as loss of digits or limbs, poor memory and concentration, or post-traumatic stress disorder. It can be prevented by vaccination, sanitation measures, such as access to clean healthcare facilities, and clean water, clean delivery, and, above all, awareness. You can help end the sepsis crisis. Tell your loved ones. Participate in World Sepsis Day on September 13th every year.
While you were watching this video, more than 70 people died of sepsis.
Sepsis is an emergency. The more people know about sepsis, the safer everyone is. Stop sepsis. Save lives.
Good evening, everybody. Today is September 13th. We observe World Sepsis Day on September 13th. Webinar Campus, dealing with classes in acute medicine, including critical care, emergency medicine, infectious disease, and all. We are proud to have associate with this World Sepsis Day and this occasion. We are also joining the event with a webinar on biomarkers in sepsis. Today, I think the audience of Webinar Campus doesn't need introduction to the speaker, Dr. Anoop Kumar. We'll be having a lecture on the biomarkers of sepsis. The key idea of this World Sepsis Day is to increase awareness on all levels of healthcare, not only in critical care, the other tiers of healthcare, including the public, regarding awareness of sepsis as the most common preventable cause of death. And we physicians involved in critical care, we are always after chasing the presence or trending of the degree of sepsis so that we can plan our management or prognosticate. Public awareness is also a key issue. That's why yearly September 13th, we observe as World Sepsis Day. Today, our topic is biomarkers in sepsis. And Dr. Anoop Kumar, who is heading the critical care department in Baby Memorial Hospital, Calicut, Kerala. And he is the founder of Webinar Campus too. I welcome Dr. Anoop Kumar for the lecture. In the panel, we are also joined by Dr. Kathy. It's over to Dr. Anoop for your lecture. Anoop, you are muted.
Thank you, Sunny sir, for that kind introduction, and welcome friends in this Sepsis Day to our forum. Initially, we thought of having a talk on advancement in sepsis, the newer definition, everything, but I think that is a very, very common topic. We all are aware about that. So we thought we will do something new related to the sepsis. So today we'll be talking on the biomarkers in sepsis, or this is one of the key methods by which you can detect sepsis very early. As Dr. Sanish has already mentioned and was shown in video, the first thing how to diagnose and detect a sepsis is by observing the patient and detecting the clinical findings. And as you are all aware, it is a dysregulatory immune response to an infection. So usually there is an immune response. When that is getting dysregulated, the people can develop multiple organ dysfunctions and can have multiple issues. So, coming to an ICU or an emergency situation, so the main confusion for us will be you need a proof to diagnose or an exclude a sepsis. On admission to ICU, that can happen. And like if you are not very confident in excluding, obviously we will land up in giving multiple antibiotics. The fever may not be because of infection always. There are many causes, as you know. Maybe a central nervous system issue. A post-operative patient within 24 hours can have fever because of many other issues. There may be a drug-related fever. There can be inflammatory issues, autoimmune issues, malignancy can present with fever. So in that situation, also it will be very difficult to exclude infection, especially in febrile patients. Immunocompromised patients may not be having all clinical signs of infection, so again, will be a bit difficult in that group. Oncohematological patients is also a real challenge, especially in an ICU situations. Autoimmune disease, which we have already mentioned. The same way, assessing the severity and again looking or assessing the prognosis is also very important. And the decision about the duration of therapy, especially the antibiotic therapy, that is also very important. Now, coming to the collateral damage. So, like you need a appropriate empiric antibiotic therapy, and again you need a broad spectrum therapy. So, especially if you are not giving an appropriate empiric antibiotic therapy, obviously the chance of mortality will be very high, if especially if it is inappropriate, as I have told. The same way, if you inappropriately start a broad spectrum antibiotic for a case which is not really because of infection, definitely it can produce a resistance, and again it can have negative impact on different outcomes. I'm not going into the antibiotic stewardship, all those things. We have to prevent infection, we have to diagnose it early, and improved antibiotic treatment includes early initiation, adequate treatment, and appropriate treatment along with the proper duration as well. So now coming to the biomarkers. So like usually we, as I've already told, we clinically assess the patient and diagnose sepsis or an infection. But obviously, as we have already mentioned, there are many challenges in that. So from 15,000 onwards, sorry, 1,500 onwards, the people were using different biomarkers in detecting sepsis. The initial biomarkers were, as you can see, it was a lactate. Then by about 1927, the leukocytosis. But this is also a very, very tricky situation. Even now, I think this is a very misused way of assessing sepsis. I've even seen clinicians looking at daily total leukocyte count. And if a leukocyte count is going by maybe 1,000 or 2,000, immediately they will hike the antibiotic, add new antibiotic, send new cultures, or if patient is not on antibiotic, you add antibiotic again. But as I've already mentioned, an increase in leukocyte count, it is very, very non-specific. Any inflammation in an ICU situation or any stressful response, or when you initiate the patient on steroid, or like the patient is having any other organ injuries, like a patient with a myocardial infarction or like a pancreatitis, or any patients with SARS response, all these patients can have a leukocytosis. So having a leukocytosis or a trend of increasing leukocytosis doesn't always mean that it is a worsening sepsis or a new onset sepsis. Then we have already, as I have already, multi-organ dysfunction, the CRP was introduced then we have hyperinflammation, SARS, etc., followed by IL-6. Now, this is a very very much discussed biomarker nowadays, interleukin 6. But it was available way back from 1989 onwards. Now, why IL-6 is gaining too much popularity is because in COVID, we look at IL-6 levels, and a very high IL-6 level may indicate a pro-inflammatory response, and sometimes people even used to uh, uh, used to decide on the immunomodulatory therapies like tocilizumab based on IL-6 values. But friends, this also should you should be very careful even in COVID patients. An elevated IL-6 values can be present in sick patients because of many reasons. Like even if you randomly look at IL-6 values in your ICU, you can see elevated IL-6 because of many other reasons. So having an IL-6 value alone, I don't personally feel it is an indication to start tocilizumab, even though some group of physicians recommends like that. And again, we don't have a strong evidence to recommend on these immunomodulatory drugs based on IL-6 levels alone. But obviously, I do agree, combining different markers, and if the patient is having a features of cytokine storm syndrome, or or when you the score based on H score, if you have a high H score, etc., or features of macrophage activation like syndrome, yes, it is true, you can start that. Then we have like the HLA, then the procalcitonin, which was there from 1993. Then again, PCT guidelines on antibiotic stewardship in 2007, 17, and sepsis 3 from 2016 onwards. So this is about the development of biomarkers, and there are so many biomarkers in pipeline and again in research. But majority of these biomarkers are not very routinely used. The majority of the time we use CRP, IL-6, or procalcitonin. So in this talk, we'll be mainly concentrating on procalcitonin. CRP, and also just like other biomarkers or like an ESR, it can it cannot specifically say whether it is because of an infection or because of an inflammation. So just like in COVID, a patient with a significant inflammation can also have a high CRP values. But obviously, a trend in CRP may be helpful in prognosticating or in assessing the patient. So now coming to the different biomarkers. So especially the trainees who are attending this program, the critical care clinics in 2020, the January edition, that was a beautiful edition on the critical care, the biomarkers in critical care, different biomarkers, not only the biomarkers in sepsis. So I have that full issue. Uh, I will share those articles in the Telegram group. The articles I have downloaded from the critical care clinics. I think that is very useful, and especially for the critical care trainees, you can use it as a reference. These all sites, all these materials, charts I have taken from that critical care clinics edition. And again, after that, there is a like coagulation dysfunction also. There is a nice clinic that is also beautifully mentioned about different coagulation defect, coagulation monitoring, endothelial dysfunction, macrophage activation syndrome, other hematological issues, etc. So please go and try to read that as well. If you need those any critical care clinic articles, you can text me in my WhatsApp, or in our WhatsApp groups, or personally. I will try to give you that through WhatsApp or through our Telegram. So now coming to the rapid detection methods of molecular biomarkers to improve the diagnosis of sepsis. So here we have different analytical techniques like microfluidics, then again proteomics and plasma protein biomarkers, genomics, then transcriptomics, and metabolomics. So these are the newer method or newer analytical techniques, and their uses are like in microfluidics is basically for rapid antibiotic susceptibility method, then neutrophil nuclear membrane deformity as an early diagnostic method. Again, there are different neutrophil based different methods are there. Even the neutrophil volume, just like mean platelet volume MPV, we were using to assess the platelet function in especially in dengue fever. Same way, there are now many papers are coming on mean neutrophil volume also. I've seen a beautiful paper from JB Peters's group from CMC Vellore as well. And majority of the newer analyzers, especially the 5-part analyzers by Beckman, Coulter, etc. They can also check at the mean neutrophil volume also. Then we have proteomics and plasma protein biomarkers, basically to identify new patterns of plasma protein interactions and response. Then we have genomics, looking at the rate of removal of these different methods like low density lipoprotein receptor, etc. I'm not going to the details of all those things. Then we have this transcriptomics, where method to define the differentially expressed genes to assess the acute and more chronic host response. Then metabolomics on measurement of metabolic perturbations in confined spaces such as pleural or cerebrospinal fluid, etc. I'm not going to all the details about all those things. Just was trying to give you an overview. The same way, when you have an infection, there is a trigger followed by sensors and effector cells will be affected. Then mediators and biomarkers will be released, and that can produce impact on organ dysfunction, and finally that will affect the outcome. So usually, like the trigger will be the lipoprotein, peptidoglycans, the bacterial DNA, etc. Or again, it can be other triggers as well, which can again lead on to complex protein systems like complement system, coagulation system, endothelial cells. Now, in in COVID, we have these endotheliitis or these endothelial dysfunction, then epithelial cells, adipose cells, then the blood and lymphocytic cells like granulocytes, macrophages, lymphocytes. In lymphocytes also, we have T and B cells. So here, based on this one, we have different biomarkers like C5a, C3a, etc. Then APTT, PT, then again protein C, etc. And coagulation system. Again, serum fibrinogen is also a biomarker. Then endothelial cells, we have different markers like selectin, etc. Then acute phase reactants like CRP, PCT, fibrinogen, and again ferritin, etc. These are all acute phase reactants. Then we have others like cytokines, interleukin 6 levels, tumor like necrosis factor, endotoxins, and other markers as well. And finally, leading on to multiple organ dysfunction. This is a usual way we see in the sepsis. So, what are the potential roles of a novel biomarker in sepsis, or in a clinical syndrome of infection and organ dysfunction? The first thing is to identify whether there is an infection or not, and to identify the etiology. And organ dysfunction also, even though like if it is not clinically defined, an early detection, then to predict the development of any other the complications, then guide the treatment. So when to start, when to stop, or change the antibiotic. The same way in fluid management or an organ supportive management, regarding the starting of dialysis or use of vasopressors, etc. And obviously to improve outcomes. So these are the situations where you use a biomarker, and majority of the time we will be using to identify whether there is an infection or whether there is not the infection is present or not. Another biomarker very commonly used in ICU will be lactate. I know that you all will be knowing about the lactate, and again in an ICU practice or like in an ABG, it is always mandatory to have a lactate levels. We usually express it in millimoles per liter, and when lactate levels are more than 2 millimoles per liter, then we'll have to look for any other probable cause other than sepsis. So when you have a lactate more than 2, It can be because of sepsis or can be because of other causes. So you should be well aware about other causes like seizures. This is very, very important. So especially when you receive a patient in a post-ictal stage into the ICU, please don't take an ABG immediately because patient will be in acidosis because the lactate level in the post-ictal state will be very high. And there are many other reasons also for lactate to be high. So in a seizure disorder, patient can have a very high lactate levels. Gut or liver ischemia, especially gut ischemia, like when you have an unexplained lactic acidosis, it can be because of a gut ischemia. Uh, then some medication, especially metformin or like carbon monoxide intoxication. Sometimes these Warburg metabolism, etc., because of some tumors. So here you have to act accordingly. So as I've already told, an elevated lactate can be because of many other reasons. If you cannot find out any specific reason, then we can look for the central the oxygen saturation. Then you look at normal or peripheral perfusion, then the difference in the PCO2. Then if the difference in central and peripheral PCO2, you can decide on the flow, then again increase the flow to normal SpCO2 to improve the peripheral perfusion. So depending on these central and peripheral oxygenation, you can again decide on like whether it is a perfusion related issue or whether it is something else. So this is how you use the lactate in guiding the treatment, and sometimes it can act as a prognostic marker, and again it can guide you regarding the fluid treatment, etc. There are again other biomarkers like CD25, CD64, CD16, and etc., especially in diagnosing sepsis. So here you can see this is a leukocyte CD64 expression. You can have neutrophil, leukocyte, monocyte, and lymphocyte CD64. This monocyte CD64 expression is having like this is a healthy people, this is a septic patient, and septic patient second row. So in septic patient, this monocyte CD64 can also give you an idea about whether the patient is having a sepsis. Again, we will have to compare with all other biomarkers. I was just giving you a clue how these biomarkers will be effective. Now we move on to the very commonly used biomarker, that is a procalcitonin. So I'll be just going through few studies where the procalcitonin is used, and again the limitations and again the advantage of using procalcitonin. So as you can see here, the sensitivity wise, the procalcitonin is better than IL-6, IL-8, etc. And again, here the CRP, IL-6 and lactate, if you consider, the PCT is comparatively more sensitive. But regarding the specificity, we will come to that later. But obviously, the CRP, IL-6, lactate also doesn't have much specificity. So this is different studies in this meta-analysis. You can see the procalcitonin is a helpful biomarker. This procalcitonin is a helpful biomarker for early diagnosis of sepsis in critically ill patient. This is a different data. You can see this meta-analysis of 30 studies, including almost 3,500 patients. This is in favor of the procalcitonin can detect an early diagnosis of sepsis. And sometimes it can be used to differentiate between bacterial and viral infection, but this is one of the early studies where you can see the procalcitonin compared to CRP and IL-6 is having a superior assessment to differentiate between viral and bacterial infection. But later on, there are many other studies, especially even in viral pneumonias, an elevated procalcitonin may not always detect that the patient is having a secondary bacterial pneumonia. So previously, the procalcitonin was extensively used in viral pneumonias, H1N1, etc. Where when you have a high the procalcitonin values, or in a dengue fever, when you get a high procalcitonin value, we suspect the patient will be having an underlying bacterial sepsis also and initiate antibiotic. But later on, there are papers which states that it cannot clearly state that there is an underlying bacterial infection also. Then this is another paper which is showing the procalcitonin, whether it can differentiate viral from bacterial community acquired pneumonia. This paper was actually showing the bacterial co-infection was better picked up by procalcitonin, which I have already told. The latest papers were not favoring these inference. Then coming to the oncohematological patients, which we have already discussed, these are the two common confusing areas: oncohematology and autoimmune disorders, especially when the patient is having associated vasculitis and all. So here, this is a diagnosis of bacterial infection and differentiation from other causes of inflammation, because the fever in an oncohematological patient can be either a tumor-induced, drug-induced, or infection-induced. So if the patient is having a fever, you cannot always say it is infection induced. There is an equal chance that it can be drug or tumor induced as well. And sometimes this study they were looking at whether the PCT can be used as a discriminator between these different conditions. But here, as you can see, there is a non-infectious group, a drug group, and a tumor group, and there is an infection group as well. So the PCT, the plasma concentration values of the CRP here and the PCT here. The CRP can be high even in this tumor group also, drug group and non-infectious. The difference is not very prominent, but the procalcitonin, when you compare between different groups, it is more sensitive. The CRP can also be elevated, but you see here the procalcitonin, very high procalcitonin is common when you compare with other groups. So this is one way by which you can differentiate, or you can think about the more possibility in hemato-oncological patients. Now coming to the autoimmune disorder patients, this is again 53 patients with 18 SLE and again other disorders. Here again you can see the procalcitonin value in infectious disease. The patients with infections, severe infections, are comparatively more compared to other markers like neuropterin, IL-6, CRP, etc. So this is the group with infection and this is without infection. So you can see the difference. Now coming to the procalcitonin kinetics provide important information on the prognosis of sepsis patient. So you have a septic patient, different groups, a sepsis patients with surviving or non-survivors, or a SARS patient. So here you can see a rapid decline in PCT values less than 1 microgram per liter indicate good prognosis, or a slow decline, it indicates a poor prognosis. This is very true. A trend in procalcitonin value is very important and useful in a critically ill patient. So if you see that significantly declining PCT values, that means that the patient is improving and they are likely to survive. At the same time, if the PCT values are in a steady state, or it is not declining well, that indicates the chances of survival will be less. This is another study called Moses study, where serial procalcitonin predicts the mortality in severe sepsis patients. This is a results from multi-center procalcitonin monitoring sepsis study. So here again you can see the primary objective of this study was to the study is to the prognostic value of procalcitonin in severe sepsis and septic shock patients being admitted in the ICU. This is basically for ICU patients, and the hypothesis was an inability to decrease procalcitonin by at least 80% over 72 hours, that is from day 0 to day 4, in response to therapy will be associated with increased 28-day all-cause mortality. That was the hypothesis of this study. And this is a prospective multi-center observational study which was conducted in 13 emergency departments distributed nationally. And the study was conducted between 2011 and 14. The patient was in severe sepsis patients. So here again different groups of patients, how the study was proceeded. And here you can see the PCT decrease less than 80%. Here you can see the 63 were alive and 15 dead, or the mortality was 30%. Whereas when the PCT decrease was more than 80%, the mortality rate was very high. Sorry, the mortality rate was very low. So this is a ICU day 4. The same study in non-ICU in day 4 also, you can see the PCT decrease less than 80%. The mortality was 10%, and more than 80, the mortality was only 5.8 percentage. You can see the difference. Almost it is just a 50% mortality. So a significant decline in procalcitonin value on day 4 after the appropriate therapy definitely indicate that the survival chance will be better, or again or if, in other words, if there is no decrease happening, the risk of death will be more. And the study also found that the baseline procalcitonin measurement greater than 2 is an additional mortality risk factor when evaluating procalcitonin measurement on subsequent days. So if initial procalcitonin is high, that also indicate it is an additional mortality factor. But always keep in mind, just having a procalcitonin value more than 2 doesn't mean that the patient will be having a high mortality risk. But I'm talking about this study alone. Later on, this was also not substantiated. So I've already told regarding the early proof or exclusion of sepsis during the admission, fever without source, immunocompromised patient. We have discussed that. Assessment of severity and disease prognosis we have decided. So we have discussed. Now on the decision of therapy duration, I think with the available present data, the procalcitonin or other biomarkers are having most important role regarding the decision on antibiotic therapy, especially a declining procalcitonin trend can definitely reduce antibiotic duration. So all other studies now, it is questionable whether it can really differentiate between bacterial and viral, whether it can really differentiate between sepsis and the sepsis mimics. But definitely a declining trend can help to reduce the antibiotic duration. That is having a reasonably good evidence presently. This is the biomarker guided therapy in an ICU. The initially, as we have discussed, the patient can have a temperature, low BP, patient can have search criteria. You do imaging and culture to look for any source, look other laboratory findings like leukocytosis, ESR, CRP, other biomarkers, etc. If the patient is having a diabetes hyperglycemia, obviously the biomarker at that point is a blood glucose. You will have to uh, uh, maintain the euglycemia, which we have discussed in detail in previous classes. If the patient is having hypotension or shock, we will have to give a fluid or the preload optimization, looking at lactate or SCVO2. If the patient is having infection or sepsis, definitely you have to take all cultures. You can even do the other PCR methods. Along with that, you can do a procalcitonin, which can help to decide antibiotic initiation and definitely on antibiotic duration. So this is one paper looking at reduction in treatment duration in a ICU patients, almost around 300 patients. The duration of critically ill patients with sepsis is based on empirical rules like antibiotic overuse and selection pressure. So the question, the question we were trying to answer in the study was: is it possible to reduce the duration of antibiotic treatment in critically ill patients without harming the patient? That is very, very important. We should not harm the patient also while reducing the antibiotic. Here you can see this is a control group and a PCT group. So the difference, in the control group, the duration was 9, whereas in PCT group, it was 6. And again, the clinical cure, other 28-day mortality, all other factors also you can see. So the serial PCT measurement definitely allows reducing antibiotic treatment duration. Here you can see almost 3 days. And nowadays, like whenever you go for higher end antibiotics, the cost for 3 days antibiotic therapy is also very huge. So by taking a procalcitonin measurement, you can definitely reduce the antibiotic usages. Again, different studies, the PCT reduces antibiotic duration. I've already told we have a strong evidence now comparing these different papers on. This is a PCT group and a control group. the antibiotic duration in PCT group was consistently low in different cohorts. Now, this is the prorata study. This is the mostly the like, or you can say something like a landmark trial where the multi-center prospective parallel group open label trial. We have a procalcitonin and a control group, both around 300 each. The antibiotic group, that was a procalcitonin based algorithm. I'll explain that. And a control group is based on guidelines. And the primary endpoints were mortality at 28 and 60 days and number of days without antibiotics by day 28. So the guideline for starting antibiotic, when the PCT values are less than 0.25, antibiotics are strongly discouraged. 0.25 to 0.5 discouraged. 0.5 to 1 encouraged, and more than one antibiotics were strongly encouraged. And the guidelines for continuing antibiotics also, when the concentration is less than 0.25, strongly encouraged to stop antibiotic. Decrease more than 80% from the peak concentration, the stopping antibiotic is encouraged. Decrease less than 80% from the peak concentration, then the continuing antibiotic is suggested. An increase of concentration compared to the peak concentration, then the changing the antibiotic is strongly encouraged. Here, that means you are not hitting the infection properly. So by this procalcitonin prorata study also, there are again the critically ill patients exclusion group. I'm not going through all the details. The recommendation like overruled, 53% in procalcitonin and 43 in the control group. And here also the PCT arm received antibiotics for 2.7 days less when you take a 28 days endpoint. Like the previous study, we hear also almost 3 days reduction in antibiotic usage. So to conclude, regarding the procalcitonin and duration of antibiotic therapy, a serial measurement of procalcitonin has a definite role in reducing the antibiotic duration in a septic patient. This is a control group and a procalcitonin and overall survival. It doesn't show much difference regarding the survival, but as I've already told, the mortality also, the 27 patients in the procalcitonin group and 18 patients in the control group. Maybe the multi-organ failure and other reasons may be the issue. Here you can see the patients receiving the antibiotic treatment. Obviously, the procalcitonin the group was having a decreased antibiotic group, which we have already discussed. This is another study called SAP study. Again, looking at the efficacy and safety of PCT-guided antibiotic treatment in a large heterogeneous set of ICU patients in a healthcare system with a comparatively low use of antibiotics. Here also you can see a PCT arm and a standard arm where patients are treated according to the local antibiotic protocol. And here the antibiotic consumption was 7.5 daily defined doses. Here it is, median duration is the 5 days in the procalcitonin guided group and 7 days in the standard group. Here also you can see almost 2 to 3 days difference and 19% relative reduction in antibiotic consumption. So this study also showed a reduced antibiotic usages, and the safety of a PCT-based antibiotic stewardship algorithm. You can see the survival. This is the procalcitonin group has a slightly better survival than the standard group. So you forget about the survival part, but all these studies consistently showing a procalcitonin based algorithm is definitely can reduce the antibiotic usages. And providing that the prorata trial, the stopping rules are effective to reduce the antibiotic use by 2 days, even in an environment with very restrictive antibiotic usages like New Zealand. So here also you can see reduced usages, a safety approach, and a proven efficacy and safety of a PCT gated algorithm for a discontinuation of antibiotics. So to summarize about procalcitonin in ICU, it contributes significantly improved early diagnosis of bacterial infection sometimes, assessment of severity of disease obviously, therapeutic decision making sometimes. PCT is better than other biomarkers, other the discussed biomarkers, and serial measurement is important. This is having a strong evidence. Other thing I've already told you the issues with that. And it's a blood test, you all know, that improves early diagnosis of bacterial infection and other issues which we have already discussed. In an emergency department also, like from check-in, triage, diagnosis, treatment, disposition, etc., like a procalcitonin value can give you, like if the patient is having a very high value, don't have a proper source, again it is not advisable to discharge that patient. You may have to admit and decide about higher antibiotics, etc. And ED patients with symptoms that may be caused by infection, like the chest pain, fever, cough, breathing difficulty, skin rash, etc. Uh, uh, Again, in these group of patients, having a high procalcitonin value will give you a high index of suspicion that this patient may be having an underlying significant sepsis. But I've already told you, having a high procalcitonin value alone does not indicate that the patient is having a sepsis. And one more thing, you have to always assess the procalcitonin. Definitely, when you ask for a procalcitonin, there is a cost factor also. So whenever you do a procalcitonin, you should have a clinical explanation also. Like if the patient is already having a chest pain, and there is a obvious patch in the chest X-ray, high leukocyte count, you clinically suspect that the patient is having a lobar or a bacterial pneumonia, then there is no point in doing a procalcitonin. But if the patient is having a like a viral pneumonia already treated, now having a new onset patches, worsening oxygenation, in that point of time, maybe like a procalcitonin will give you an additional benefit that the patient may be having a secondary onset bacterial infection. This is again antibiotic use, the use or misuse in Europe, the guidance with procalcitonin. Here again you can see when the procalcitonin values are very low, the bacterial etiology is very unlikely. And when it is more than zero point 0.5 and all, I don't think this study it was saying like that. Or when it is more than 2 or so, the antibiotic usage is strongly encouraged. So now coming to the different groups like pneumonia, upper respiratory tract, severe sepsis, meningitis, the procalcitonin is having a higher significance. Other like acute COPD exacerbation, the asthma, like infection in asthma, this is also sometimes helpful. Like normal procalcitonin in an asthma patients without any proper, an obvious X-ray patches, you don't have to put the patient on antibiotic. A patient with a congestive heart failure sometimes can have lung infiltrates, etc. You can confuse it with the lung infections. So procalcitonin can guide the abdominal infection and pancreatitis. This I don't know how much it will be helpful, because especially when the patient is going for a severe SARS response, procal also may be high, but the serial values can guide you whether the patient is going for a secondary infection. A post-operative infection is very difficult to comment, especially following a major surgeries. You can get a high procalcitonin values. So these group of patients like neutropenia, arthritis, endocarditis, etc., the value of procalcitonin is minimal compared to other sites. This is again another way of using the procalcitonin, especially when the procal values are more than 2, etc. It is very high chance that the patient can have a bacterial infection. This is from the BMC journal. So here again, this is antibiotic treatment is strongly recommended. And again, you have to consider the cause of consider the course of a PCT. That dynamic monitoring is indicated. You will have to repeat the PCT in subsequent days, and the trend in PCT which we have already discussed. If antibiotics are withheld, control PCT after 6 to 24 hours. Then depending on PCT value, you can decide whether your decision is correct or not. These are the present status of PCT. This is again from the Critical Care Clinics article which I was discussing initially. This is three trials, like the Lenkova trial in 2018, VIRS 2018, Pepper in 2019. So this meta-analysis, this first one was showing looking at 10 trials, second 11, and third 16, and altogether 5,000, nearly 5,000 plus 10,000, and almost 13,500 patients. So here what these meta-analysis was showing, there is no effect on mortality, almost 1.5 days in reduction in antibiotic. The second meta-analysis was showing a decreased mortality and a 1 day reduction in antibiotics. And the largest meta-analysis was showing decreased mortality, a 1.3 reduction in the antibiotics duration. That's what I was saying. All these meta-analysis and trials has clearly shown that the procalcitonin guided antibiotic therapy can definitely reduce the antibiotic duration, may help you to reduce mortality, but whether it can precisely tell it is a bacterial infection, very difficult to say at this point with the available evidences. Now, before concluding regarding the biomarkers in severe COVID infection, this is again, we have different biomarkers like CRP, then again serum amyloid A, IL-6 values, LDH, the white cell count, D-dimer, platelet count, cardiac troponin, and renal biomarkers. But those who are treating COVID patients also, you have to judiciously use these biomarkers. I've seen some clinicians doing like daily IL-6 monitors, daily CRP monitoring, or daily D-dimer monitoring. It will simply add on to the cost of treatment. You assess the patient clinically. If the patient is having a worsening in oxygenation or a new infiltrates, or say the patient is having a new fever spikes, so those group of patients, obviously you can do these tests and see what is the trend. And again, if the patient is completely asymptomatic, and sometimes because of the rules in your place, sometimes they may get admitted. If they're completely asymptomatic and don't have any comorbidities, you don't have to look for these biomarkers in that group of patients. And again, looking at IL-6 values alone, deciding on tocilizumab, we don't have any evidence at this point of time. But along with IL-6 and other biomarkers and say H score or like other HLH criteria, yes, maybe you are justified in starting a tocilizumab as per the evidences available. So thank you so much. I was just trying to give you an overview about the usage of biomarkers in different situations, and especially the most commonly used biomarker, the procalcitonin, its use in sepsis, and how to use that procalcitonin to guide antibiotic therapy. So thank you so much, and we will take the questions now.
So thank you so much, sir. This is Dr. Khyati here. Just want to comment on the last slide which you showed about the biomarkers in COVID-19. So as we are talking about procalcitonin today, there are a lot of studies already being done in China and Taiwan. These countries have already included procalcitonin in their protocol for COVID-19 for risk assessment, basically, that the patient might do bad if the procalcitonin is more than 0.5. And what they have seen is that if there is a procal level of more than 2, the chance of mortality increases 5 times. So also we've seen that Indian states like West Bengal and Karnataka has also included procalcitonin in their treatment guideline for gauging the risk assessment and also to determine if there is any bacterial superinfection. So those are again two indications recently we have found out for procalcitonin in particular scenario as in COVID-19. So with that, I would like to take few questions which are asked in the chat window. The first one is asking about the role of serum ferritin levels in infections.
Yeah. Before that, I'll just take a question from this question and answer session. I was talking about that. This is like how often we will repeat procalcitonin. I've already explained that. Like if the patient is on antibiotic, the serial values you can take and decide on whether to stop the antibiotic or whether your antibiotic is really responding, or if the serial values are showing an increasing trend, as I've already shown, it can indicate that the patient is having a new onset infection, or whether your empiric antibiotic is not working in that patient, and how often you repeat procalcitonin. I personally don't prefer going by any protocols, because that can really add on to the cost. You assess the patient clinically, then you decide whether how often you have to repeat. Based on that, you can decide. So obviously, if you can reduce the number of antibiotic days by using a procalcitonin level, definitely it can reduce the cost as well. Now, coming to the biomarkers, 1 minute. Regarding the serum ferritin. So the ferritin is basically an acute phase reactant. It can increase in inflammatory situations, like especially when you have very high ferritin values, you have to think about the possibility of like a macrophage activation syndrome. So especially you will get a very high procalcitonin values, like more than 10,000, etc. And another thing what we have observed is, like, you have an intracellular infection and an extracellular infection. Usually in an extracellular infection, the procalcitonin is having a better sensitivity. Whereas in an intracellular infections, like salmonellosis or brucellosis, etc., serum ferritin may be a better biomarker. But again, there is no point in looking at ferritin level alone. Like, you can do an H score, which I've already mentioned. So looking at a H score, even if the ferritin values are slightly less than 10,000, the chances of macrophage activation like syndrome will be more. Or by looking at other parameters, even if ferritin value is more than 10,000, it may not indicate that patient is having a macrophage and activation like syndrome. Previously, it was called macrophage activation syndrome. Now, the better terminology in sepsis is macrophage activation like syndrome, or MALS. Antibiotic
Thank you, sir. Yeah.
stewardship, please,
Stewardship.
can you yeah. So I've already told you that how to use that. One thing, if the procalcitonin values are very less, like more than less than 0.5, etc., it is unlikely that it can be an infectious cause, and it is strongly discouraged to use an antibiotic. The same way, if there is a significant reduction in the serial procalcitonin value with a clinical improvement, obviously you have to assess the patient clinically also. Then you can think about stopping the antibiotic. And after stopping also, if the patient is having a clinical deterioration or something, you can repeat the procal and see whether it is steadily declining or again showing an increasing trend. So that is how you can use the procalcitonin values. Any serial biomarkers useful in fungal infection? That is another big topic, biomarkers in fungal infection. Because of a shortage of time, I have not included. There are even many papers even coming in COVID also regarding the galactomannan, and again other biomarkers in fungal biomarkers in COVID sepsis also. That is, there are situations where you can look at serial values to look at therapeutic response. More than serial response, which, sometimes when you have a clinical suspicion, we use these mannan, galactomannan, etc. Any other questions? If you can, if you raise the hand, we can allow you to talk. Or any other point if you want to clarify, uh, you can ask that. And as I've already promised, I will try to share that critical care clinics articles on biomarker use in ICU in our Telegram group. Over to Dr. Kadi.
Thank you so much, Dr. Anoop, Dr. Sanish. And on behalf of Thermo Fisher Scientific, we always work towards reducing the risk of using or misusing antibiotics for a longer duration, with the role of procalcitonin as a tool for antimicrobial stewardship. And today, as the occasion of World Sepsis Day, we need to work towards reducing the mortality and reducing the morbidity for sepsis. So thank you so much, Dr. Anoop, Dr. Sanish, and the entire team of ISCCM Calicut Kochi for giving us this opportunity to put forth the literature about procalcitonin. And thank you so much, Dr. Anoop, for taking all of us through those papers and telling us in brief about the importance of procalcitonin. Thank you all for being here today with us at the digital webinar. And from all the team of Thermo Fisher Scientific, we wish you a good and healthy weekend, and stay home, stay safe. Thank you so much. With that, we wrap up the meeting today. Sir, any final comments before we close the meeting?
I think on the occasion of World Sepsis Day, be the physicians working in the critical care scenario, we should also put a word in our social media platform or to the lay public regarding sepsis, because whenever we do the counseling, the biggest hurdle is people may not equate the word sepsis with mortality, the risk of death, though this is the most preventable cause of death. So while observing the World Sepsis Day on September 13th, that is also important, because as we mentioned this word sepsis more commonly in our regular conversations, this awareness also will creep up in our society. Within our fraternity, we think about counseling, antibiotic stewardships, biomarkers and all. That's another side of it. We need to concentrate on the public awareness side also. So Dr. Anoop, with your closing remarks, we can wind up today.
Yeah, so like again, another thing I wanted to emphasize is picking up a sepsis in an ICU scenario, like especially during a close monitoring, may be easy. But to reduce the mortality, you have to pick up from the like an OPD patient or from an emergency department or a patient admitted in the ward. So if you detect early based on the like hemodynamic instability or the problem with the sensorium or an organ dysfunction, and starting an antibiotic and source control, both are having like equal importance. So I think early antibiotic was majority of the time overemphasized. I'm not saying that early antibiotic is not indicated, but source control is also having a equal importance or a more importance than having like a early antibiotic usage also. So with that, I think we will end today's program, and thank you for joining us in this platform.
Thank you. Good day.
Thank you so
Thank you,
much.
Kathy.